Good evening, everyone. My name is Shantae Davies Balch, and I will be your moderator for today. I want to start by welcoming you to Candid Conversations, COVID-19 and the Black and African American community. What's next? So we proudly present this webinar today. Our sponsors, California Department of Public Health, the Sierra Health Foundation, our Vaccinate All 58, and then of course, the California Black Health Network. We are going to move through also, a special thank you to our promotional and event partners, and that's Roots Community Health Center, also Long Beach Forward, and the Bay Area Community Health Advisory Council. We're going to start by just talking through some housekeeping items, and then we're going to jump right into our town hall. We are extremely lucky today to have our California Surgeon General with us, Dr. Nadine Burke Harris, and we only have her for about 20 minutes. So a couple quick reminders. We really encourage everyone to use the raised hand feature during today's town hall. That can be accessed at the very bottom of your screen. And you will be acknowledged, and then we'll be able to ask your question out loud so that everyone can hear your comment. Once we get to the Q&A session, once you're called upon, you'll have about 15 seconds to ask your questions and about 30 seconds to make your comment. And we are cutting that down a little bit so that we can make sure that we have plenty of time to hear from Dr. Nadine Burke Harris and get to our Q&A. So lastly, I just want to remind our attendees that you are muted and you will be unmuted once we get to the Q&A session and you have your hand raised. So let's start by welcoming our panelists today. Again, we have our State of California Surgeon General, Dr. Nadine Burke Harris. We also have with us Dr. Oliver Brooks, Chief Medical Officer at Watts Healthcare in Los Angeles. We also have Dr. David Tom Cooke, Associate Professor and Chief of the Division of General Thoracic Surgery at UC Davis Health in Sacramento. And then we also have with us Rhonda M. Smith, Executive Director of the California Black Health Network, and they are statewide, but she is based in Sacramento. So our topics of discussion today, we're going to focus on vaccines and vaccination updates. We will be talking about what's new, specifically with Johnson & Johnson. We'll be talking about the science behind the vaccines, harm reduction guidelines, and we'll be talking about equity and access. And so with that, I would like to turn it over to our California Surgeon General, Dr. Nadine Burke Harris.
Thank you so much, Shantae. And I understand them. We'll dive in pretty quickly to taking questions, but I wanted to start by just highlighting specifically when it comes to the Johnson & Johnson vaccine. First of all, I think that as many folks know, we received word yesterday from the CDC and the FDA a recommendation to pause use of the Johnson & Johnson vaccine. When we use all of our vaccines in the United States, we very, very closely track potential significant side effects through a national system that's called the Vaccine Adverse Event Reporting System, and that is the VAERS, V-A-E-R-S. And in this circumstance, the VAERS system did identify 6 cases of a very rare but serious condition called cerebral venous sinus thrombosis, which is clotting of the clotting that forms in the veins that drain the brain. So this is very, very rare, 6 cases out of 6.8 million individuals who have been vaccinated. Actually now 7.2 million individuals who have been vaccinated so far. And so the CDC and the FDA saw this, what's called a safety signal. It's just a little, hey, we're seeing this these very rare cases, and decided to, in an abundance of caution, pause use of the vaccine at this time so that we can further investigate and dive into these cases, better understand what's going on, whether or not we believe that it is associated or due to the vaccine, and whether or not any change or in the indication and use of the vaccine is warranted. So I will start with that. Here in California, I'll just say that California's vaccine effort is guided and grounded in the principles of safety, equity, and transparency. And in this situation, one of the things that I think is really important for the public to recognize is that this is an example of our safety infrastructure, our vaccine safety infrastructure in California working in the way that it's supposed to. I think folks have heard me say before that if there's any concern, any question, a whiff of a question about safety, we pause use of vaccines and we investigate. And that's exactly what's happening right now. And so with that, I'm happy to take any questions.
Thank you so much for that overview, Dr. Nadine Burke Harris. We do have some questions here that we'll start with. So our very first question that we have is, will we eventually resume use of the vaccine? And we know that you've partially answered that, but just to make sure that our folks out in the community are clear, will we eventually resume use of the J&J vaccine, or will it be pulled from the market completely?
Well, I want to say the short answer is that really depends on what we find, right? So we are I don't want to prejudice that answer by saying yes one way or the other, but what I can do is say, what are the options, right? So certainly one option would be to say, okay, we're not going to use this vaccine anymore in the United States. And on the other end of the spectrum, there's, we looked at the information, we're going to make no change in the use of the vaccine. And then in between, there are a lot of options as well. For example, there are several options as well. For example, we may indicate the use of the vaccine for certain populations of individuals. For the 6 cases that were identified, they were all women. They were all of them whose race was identified. I think at least 5 out of 6, I would have to double confirm whether it was all 6, were Caucasian. And, one individual, one woman was using oral contraceptive birth control pills that can also increase the risk of clotting. And so this is the information that the CDC and the FDA is looking at to say, maybe it's potentially would be used in approved for use in older individuals, because, for example, the age ranges of the individuals affected were 18 to 48 years old. So maybe it's for folks who are over 50. So there are different options in saying either we could use continue use, but with certain conditions or caveats, or continue use with labeling, right? That makes the public aware of certain risks. So for example, with the Moderna and the Pfizer vaccines, there is a small but significant, there's a small but present risk of anaphylaxis, right? And as a result, we monitor folks for 15 minutes after receiving the vaccine. Well, something that is very rare but serious, like cerebral venous sinus thrombosis, is similar in many ways to anaphylaxis, in the sense that it may be something that we make the public aware of about the rare risk, let the public know what the signs and what to look out for, and let doctors and healthcare clinicians know what to look out for. So there's a whole spectrum of options between, continue as we've been and pull it from the market.
Thank you so much for that response, Dr. Burke Harris. Our second question is related to underlying health conditions. And the question is, are patients with underlying conditions more susceptible to getting blood clots from the J&J vaccine?
The type of blood clot that was that these 6 patients experienced is a very, very unusual type. It's a type of blood clot where, so normally we have blood cells in our blood called platelets, and they help our blood to clot. In this case, each of the patients had very low level of platelets, and it was associated in this very rare configuration of low platelets that was associated with increased risk of clotting, of a clotting event, right? It's called thrombocytopenic thrombosis. And in any case, so from that standpoint, what we know now is that each of these 6 patients had clotting events and low platelets. And it's going to require a lot more investigation to understand whether or not there are specific predisposing risk factors, whether there are any other conditions that would predispose. But I do want to be clear that it's not just any clotting, but this very specific and rare form of clotting in the setting of low platelets.
Thank you so much. And I think we just all learned a new word today, except for the physicians or clinicians on the call. Was it thrombocytic? Thrombosis?
Thrombocytopenic.
Okay, I wasn't even close, but thank you for that. So our next question comes from one of our guests, Craig Tenson, and his question is, how will the autoimmune community be addressed, or people like himself that is immune compromised, on the topic of Johnson & Johnson vaccines?
Okay, I want to make sure I understand that question appropriately or correctly, in the sense that whether or not we feel like there's a greater risk for the autoimmune, for individuals who have autoimmune conditions.
Okay, let me, I did a little paraphrasing there, so let me just read the question directly to see if that helps. Will they address anything regarding the autoimmune community or people like myself that is immune compromised on this topic?
Okay. So let me see if I can answer this with as much information as I was able to understand from the ACIP meeting today, the meeting that the CDC held when they reviewed this data. One of the things that they are looking into and understanding is whether or not, so all of the patients who had this very rare condition with low platelets had antibodies to platelets. So to the question, autoimmune means your own body's immune system is attacking part of your body. In this case, the immune system was attacking platelets. We don't have enough information at this time to make any further conclusions or to further understand the overall implications of these findings related to immunocompromised individuals or individuals who otherwise have autoimmune conditions. And this is part of the information that the CDC and the FDA will be looking into, really trying to understand what is the pattern, what is the, as we call it, the epidemiology, what are the conditions that may predispose to this, and what are the mitigating factors. So we don't have enough information yet to answer that question.
Wonderful.
But I will say that when we do get more information, we will immediately get that information to the public.
Thank you, Dr. Burke Harris. So again, I just wanted to let our audience know that we're very lucky to have Dr. Nadine Burke Harris with us today, and she is only available for a few more minutes with us. Before we open it up to the rest of our panel to answer our next question, I just wanted to provide a couple more minutes for you, Dr. Nadine Burke Harris, in case you have any closing thoughts that you want to share with the audience, because I know you have about 2 more minutes before you have to hop off.
Yeah. So, I think the thing that I would want to say is that I got the Johnson & Johnson vaccine. I think that, which I'm glad I did. I'm glad that I'm protected, recognizing that the risk of COVID is so significant. And when we're talking about 6 cases among over 7 million individuals vaccinated, of course, we take every case, every concern very seriously. And at the same time, for anyone who is, one of the big questions is, should people be worried? Should people be concerned? And I think that the answer, generally speaking, is no. What we want to make sure is that if individuals know what to do, and that healthcare providers know what to do. One of the important things is because of the very unique and very rare presentation, the typical treatment for clotting is actually not the treatment that is indicated in the situation. And so one of the reasons why the CDC and the FDA decided to put a pause on the use of the vaccine and issue this health alert is also to help healthcare providers know what to look out for. So if anyone out there is concerned, if anyone who has received the Johnson & Johnson vaccine within the previous 2 weeks, because really the onset was within that time, within essentially 6 to 13 days. So if anyone has received the Johnson & Johnson vaccine within the previous 2 weeks and developed severe headache, severe abdominal pain, I think it's common to get malaise, but if there's severe fatigue and malaise or pain in a leg or anything like that, absolutely reach out to your healthcare provider. For healthcare providers, I want to encourage to look at the health alert and make sure that if there's anything you're concerned about, that you're reporting it to the Vaccine Adverse Event Reporting System. And in this situation, the system has worked. And it has worked to keep the public safe. And that's the key piece, is that we want to maintain public confidence in our process, in the safety and efficacy of our vaccines, and in our ability to be our ability and our commitment to be transparent with the public if there are any questions or concerns.
Thank you so much, Dr. Nadine Burke Harris, our State of California Surgeon General. We're so happy that you are able to take time out of your schedule to join us this evening. We enjoyed hearing from you, and we will look forward to seeing you again very soon.
Yes, thank you. It's my pleasure.
Thank you so much. Okay, so we do have some questions for our panelists. I'm going to open it up to Dr. Oliver Brooks, Dr. David Cooke, and Rhonda Smith. So the first question that we have coming from Our audience for the panel is from Wendy Sims Moten, and I hope that I'm saying your name correctly, Wendy. And the question is, will the COVID-19 vaccine become an annual vaccine like the flu shot? And
I will speak to that.
okay, I was going to say, Dr.
Yeah.
Brooks, I'll start with you and then move to Dr. Cooke if you have anything to add.
Okay, so, and good late afternoon, early evening to everyone. It's truly an honor to follow the Surgeon General, Dr. Nadine Burke Harris, and thank you for hosting this forum. And I'm going to underscore one thing she said twice and say the third time. You all should be very pleased that our systems worked, where this was picked up. 6 cases out of 7 million doses given, 1 in a million, less than 1 in a million. And we found it and we took a pause. So for those that are worried about the safety and the efficacy of vaccines, this proves that our systems work. So remember that. Don't look at this as a failure. This is a success, that we found something and we're taking a pause, and a pause is different than a halt. Now, in terms of the question, so the messenger RNA vaccines, the 2 that are now in use, Pfizer and Moderna, can be adjusted because the biologic technology is so advanced. Will we have to have an annual one? We do not know. We don't even necessarily know if we're going to need to have any more at all. So as we are seeing the variants show up, variants are just it's like the same virus but wearing a different shirt, or moving a little slower, faster. It's trying to outwit your immune system. So with the appearance of these variants, I would say that, along with the fact that it is a very deadly virus, and that generally speaking, it seems to spread a little more readily than influenza, less so than measles, and that it's worldwide, that there is the potential for the need for an annual vaccination. But we will know that in another, 9 months or so.
I would echo Dr. Brooks, and we're collecting this information now. So for instance, I was a participant in the Pfizer vaccine trial that was randomized to placebo versus the messenger RNA vaccine. And I received my first dose last August, my second dose in September, and I'm still getting my blood drawn every 6 months to measure my antibodies. So that question would be answered. Also, an extension of the Pfizer trial, they are looking at quote unquote booster shots, and to determine antibody level production with booster shots, and measuring rate, if any, of COVID infection. So hopefully we will have answers to that question on whether we need booster shots or an annual shot, such as the flu vaccine, as these trials continue to unfold.
Wonderful. Thank you so much, Dr. Brooks and Dr. Cooke. Rhonda, did you have any comments to make at this time?
No, I'll leave that to the medical professionals.
Okay, wonderful. So thank you so much. We have another question coming from our audience for our panel. So all of the vaccines received emergency use authorization. Is there a final stage of approval or another stage of approval that these vaccines will need to go through? And Dr. Cooke, let's start with you, just speaking from your experience with being one of the trial participants.
Yeah, so that's a very astute observation. And these, because I hear language saying that these vaccines are FDA approved, and they're not FDA approved, they're FDA authorized via emergency use authorization. So what that means is that a panel at the FDA, some of whom are longstanding FDA officials, and others are invited experts, including Dr. Hildreth, who's an African-American president of a medical school, review data submitted by the different companies from their clinical trials. And they go through that data with a fine-tooth comb and determine that in a setting of a pandemic or an emergency, can they authorize, is it safe to authorize use of these products? And so there have been 3 vaccines that have undergone emergency use authorization. That's the Moderna and the Pfizer vaccine, as well as the Johnson & Johnson/Janssen vaccine. Now, as Dr. Burke Harris pointed out, the system then continues to look at the safety and efficacy of these vaccines. And if there are any issues, there can be a pause, similar to the emergency stop button in driver ed school. When you're driving, you can stop the car or take over the controls. And then study the information. Once we have all this information from this pandemic, then ultimately there will be a final approval process where these vaccines become FDA approved. So that doesn't mean that the products are unsafe. It's just that they're released to the public for emergency use. We're still collecting data. And ultimately, we hope that all 3 of these and perhaps more vaccines in the future will be FDA approved.
Wonderful. Thank you so much, Dr. Cooke, for that. So I just wanted to remind our audience members that we do want to hear from you. If you do have a question, please use the raise hand feature. It's at the bottom right-hand side of your screen. You should be able to find that under the more section where the 3 dots are. So again, if you have a question, please utilize the raise hand feature so that we can make sure to answer your question. Our next question I'm sorry, Rhonda.
Well, I wanted, before we move on to the next question,
Sure.
if it's okay, I wanted to thank Dr. Cooke for actually participating in the clinical trial. And I know one of the things that we hear from the community, and especially as it relates to vaccine hesitancy, is doubt about whether or not the vaccine is intended for people like us. And so I'm sure the 2 doctors here can comment on this far better than I can, but I do know that based on my understanding, the clinical trial participation and the diversity of participation is higher than some of the other clinical trials for other drugs that have been developed over the years. So I was wondering if either of the doctors could speak to that for the audience to clarify that.
Thank you,
Yes.
Rhonda.
So, yeah, and obviously Dr. Cooke can. We're 12% of the population in the United States. We were 10% of the clinical trials for the 2 vaccines. I'm not sure about the J&J, but I believe it's about the same. And I'm past president of the National Medical Association. We have a Project Impact, increased minority participation in clinical trials. Historically, we have not been in the clinical trials, so thanks for bringing it up, Ron. So the 10% of the 30,000 with Pfizer and 43,000 and Moderna was excellent participation, and we are very pleased with that. So we do know that the vaccine is safe and effective in African Americans because we were directly in the clinical involved and included in the clinical trials.
As Dr. Brooks points out, the diverse participation was intentional. So we're looking at 10% African Americans, which is unprecedented almost, and then up to 25% Hispanic as well. And then 50% women, and you have elderly as well as participants in these trials. So really a lot of underserved groups. And I think, I mean, we'll get into probably, the glass half full aspects, but this kind of shows how we can do clinical trials if we purposefully reach out to underserved communities with full transparency and safety, and identify therapeutic products that would benefit all of our communities.
Yeah, and then just as it relates to vaccine hesitancy again, and maybe even building confidence or more confidence, all of the other medications that the Black population actually do take as part of their prescription therapy, like for heart disease or hypertension, the level of diverse participation was fairly low, but they have confidence in those drugs that they're taking to treat their condition. So there's no reason why there shouldn't be the same level of confidence, in this case, far more confidence because of the diverse participation. So I think that's something that's really important for us to really emphasize. If they have faith and confidence in the drugs that their doctor's prescribing for them, for their other health conditions, this, should really breed a lot more confidence.
Thank you so much for that, Rhonda, Dr. Brooks,
Sure.
and Dr. Cooke. Really appreciate that. Before we move on to the next question, did we have any final thoughts on around vaccine hesitancy or access? Okay, wonderful. So just kind of continuing the conversation around the science behind the vaccine. The next question is regarding folks who have already had COVID. Should they move forward with getting the vaccine? And I'm just gonna leave that open to our two physicians to answer.
I'll take it. The answer is yes. There is clear evidence that the vaccine affords better protection than natural disease, which I'll state is relatively uncommon. Natural disease generally gives you excellent protection, but not with this particular virus. You develop antibodies when you get the disease. They last, we know that they seem to last for approximately 90 days. So in the labeling of the two vaccines, the messenger RNA vaccines, there is no statement regarding delaying, well, actually 2 weeks, but there are general recommendations that if you had COVID-19, you wait 60 days before you get vaccinated. And that's primarily because you have circulating antibodies. Take the vaccine, the antibodies may just denature the vaccine itself. The important answer, though, is yes. If you have had COVID-19, you definitely still need to get vaccinated.
Wonderful. Dr. Cooke, I'll follow up with that and ask you, will receiving a COVID vaccine alter your DNA in any way?
The answer is no. So in regards to the 3 vaccines that are on the that are available to us, the 2 are grouped together, Moderna and Pfizer. And those vaccines encode what's called messenger RNA. So think of messenger RNA as a blueprint to create protein. So that RNA enters our cells, and then our protein making machinery takes that blueprint, prints out the spike protein that's encountered on the COVID-19 virus. And that boosts our immune system, such as antibodies, to then attack that spike protein and therefore attack the virus as it enters our blood. The other vaccine, the Johnson & Johnson vaccine, as well as the AstraZeneca vaccine, which is not available here, but available in Europe and Canada, is what's called an adenovirus vaccine. And that is another virus, a technology that's been used for many years in science. And that encodes a DNA, a short piece of DNA. That adenovirus is not active, so it can't, quote unquote, infect you. And then your cells take in that DNA and then convert that DNA to RNA and then to print out the protein. That DNA does not encode itself into your quote unquote genome. So you cannot get COVID-19 from the vaccines, and the DNA that is in the Johnson & Johnson and AstraZeneca vaccine will not be incorporated into your own DNA or your own genome.
Wonderful, thank you. So now it looks like our audience wants to get into some more practical questions around what they can do. And folks want to talk about traveling. So when can folks begin to go out, travel, see loved ones and friends again? If you've been fully vaccinated, but the folks that you want to visit have not been vaccinated.
So I can speak to that some. First, you need to tell your friends to go get vaccinated. So that's step one. As of April 15th, which is what, tomorrow, anyone can get vaccinated, so they will be eligible. So got a couple of questions. So travel, April 2nd, California updated their travel advisory. So for those that are fully vaccinated, you can travel, let's say within the United States, and when you come back, you do not have to isolate or isolate, unless you're symptomatic, and that's a very important part. If you want to go around unvaccinated people, you can, with less infection control. I don't know how Dr. Cooke feels about this. They're telling us now if everyone's vaccinated, you don't have to practice social distancing or masking. I do that some. I guess I'm so used to wearing a mask and keeping my distance, but I still do that. But if you are vaccinated, you may go into a household of individuals that are unvaccinated if they are all low risk. In other words, no underlying medical condition, not greater than 65 years, greater than or equal to 65 years of age. I think that's really important because one of the benefits of being vaccinated is you have some more freedom. So the freedoms, again, be around other people with comfort that are fully vaccinated, go into a household that the people are at lower risk, and travel without returning and having to isolate.
Yeah, I would echo that. I haven't seen my parents and sister in over a year, outside of FaceTime and Zoom and all those things. And I'm going to see them this weekend because everyone in the household is vaccinated. The CDC says that if everyone in the household is vaccinated or in a group setting, then you can meet without a mask. But if there are individuals who aren't vaccinated, then they should wear, everyone should wear, a mask, especially others individuals. I'm not bringing my daughter, who is 12, and who, to the chagrin of my parents, because they don't really want to see me, because she has not been vaccinated. And in theory, I don't know if she is an asymptomatic carrier, and not to put her at risk as well. That's why we encourage everyone to get vaccinated once a vaccine becomes available to them, so we can get back to our loved ones and travel and et cetera.
Thank you, Dr. Brooks and Dr. Cooke. We now have a question for Rhonda. We want to discuss equity. So how has COVID-19 affected the current health disparities African Americans are experiencing? And also, what are some of the solutions to battle this?
I think that could be a town hall unto itself. But when I talk about COVID, sometimes I say it's like the good, bad, and the ugly of it, right? And so, one of the good things, if we can say something good has come out of COVID, is things that, especially Dr. Brooks and Dr. Cooke have known for a long time, is that health disparities in the Black community, it's not something new. It's been around for decades. But the good thing is that COVID has put a spotlight on health disparities in the Black as well as the Latinx community. And then the other part that is bad is that it has exacerbated those health disparities. And we see the disproportionate number of Blacks and Latinos dying from COVID, contracting COVID as well as dying from COVID. And so, there's a lot of reasons for that are very complex. We could, talk about the social determinants of health. We could talk about, things that happen in terms of individual behavior and, people's attitude and behavior around that. We could also talk about, what I call the big elephant in the room is the impact of racism and racial bias on the health and well-being of Black and Brown people and how decisions get made about the care for Black and Brown people. So it's a very complex issue, one that we at the California Black Health Network are working to address as a statewide organization. But we know that, there's been a lot of work done at the individual and community level to address health disparities, and now even more so in the age of COVID. But there hasn't been as much of a focus, whether it's definitely related to policy changes at the system level. And so we're working and focusing more and more on addressing policy and driving policy initiatives that affect changes within the system itself, like we see with SB 464, the perinatal equity bill requiring perinatal providers to actually go through implicit bias training. Now, that may not be the silver bullet, but it certainly is a start. But we hope to see more systematic changes and structural changes, as well as behavioral and cultural changes within the system of care. So again, great policies that have happened for people seeking care, not as many yet for those providing care and at the system level. So we recognize that that is an important element of addressing health disparities and achieving health equity.
Thank you so much, Rhonda. It's always a pleasure to hear you talk about equity and access. So we have 2 questions from our audience. We will hear first from guest CET, and then we will hear from Julie Linksweiler. So CET, you are able to unmute yourself and your question, please.
It's been reported that some vaccinated persons have contracted the virus. I'd like to know, do we know why? Do we know how many? And especially for people with compromised immune systems, do they need to be worried?
Well, I'll chime in, and Dr. Cooke obviously has indicated. First of all, why? The vaccine is 95% effective. Well, the two, 94, 95% effective. Again, I'm speaking primarily to the mRNA vaccines, which means they're 5% not effective. So 1 out of 20 may get it. But when you get a lot of people vaccinated, you get toward herd immunity, they're going to be less likely to get it. If they're immunocompromised, if that's what you said, that might be part of why they didn't they got it, because their immune system didn't respond as well to the vaccine. Third reason may be that the vaccines take 2 weeks after the second dose to be fully effective. So if they got it between dose 1 and dose 2, or less than 15 days after dose 2. So these vaccines are not perfect. They're actually close to perfect when eliminating death and severe illness. But they're not perfect. But they are clearly better than nothing, 95% better than nothing.
Yeah, I would echo that. I think it's important for us to understand expectations of the vaccines and how the clinical trials were designed. So you take Johnson & Johnson, which is the most recent one to have, and all this data is publicly available on the FDA's website. Their efficacy was about 70+% in the United States and almost 80+% 28 days after injection. So that means that X number of individuals did acquire COVID-19. However, in that study, there were 0 deaths from COVID-19. And that's even including South Africa, with all the variants in Brazil, there were 0 deaths from COVID-19 and only 2 hospitalizations. So really the vaccines, whether it's Pfizer, Moderna, or Johnson & Johnson, the key statistic is moderate to severe symptoms from COVID-19 and healthcare utilization. And so these vaccines prevent death and moderate to severe symptoms, as well as requiring to go to the hospital and being treated. So those were really the primary endpoints for these clinical trials. So if you get COVID-19 after being vaccinated, it's almost unheard of from dying of COVID-19 or having to go to the hospital and be admitted and put on a respirator or things like that.
Thank you so much, Dr. Cooke and Dr. Brooks, for answering those questions. CET, thank you for your question. Next, we will hear from Julie Linksweiler. Julie, you are able to unmute yourself.
Okay, I did. Okay.
Okay, Julie, we can hear you. Your question, please.
Will young children ever be vaccinated?
Okay, so I'll address that as a practicing pediatrician. So first of all, young is obviously a relative term. I still consider myself young, but I'm not a child.
It's not the years, it's the mileage.
Got a few miles. Right now, I think Pfizer is going to be presenting for use of age 12 to 15. It's either Pfizer or Moderna. I can't even remember right now, and I apologize. So the studies are ongoing. The way most vaccines work in terms of getting a childhood indication is that they get the adult indication, then they do what are called bridge studies, where they have the same studies that they did, but they do them in children younger and younger ages. And there are studies ongoing now in children down to either 2 or 6 months of age. And again, sorry, I can't remember exactly. And then if they find the correlates of protection. So what that means is, okay, Dr. Cooke spoke very eloquently about the fact that death and hospitalization, that's a clear endpoint. You may get COVID. I don't want to die from COVID. I don't want to end up in a hospital where other things can happen to me, like other infections. So you get that from antibody response and immune response. So what they're going to look for in the children is give them the vaccine and look for antibody response and overall immune response. And if they get that, that's correlated with protection, then it can be approved in children. So the short answer is, I believe that in the long run, children will be probably allowed to be vaccinated, but it even gets deeper because we're finding that there are like almost no deaths in children and very little COVID-19. So the question will be, what is the purpose of even vaccinating? So there is this advisory committee on immunization practices, the ACIP. So the FDA approves it, and the ACIP says, how do you use it? So ACIP will have to determine, well, we have this vaccine that's theoretically approved or is approved in this particular age group, say 12 to 15 years of age. Now, how do we use it? We use it on just children that have underlying conditions. Do we use it in children where there's an outbreak? Do we use it on all children? So that question is a very important question and a simple question, but the simple questions are usually the most difficult to answer. So in short, I believe that there will be a vaccine, a COVID-19 vaccine for children. So the next step will be, we have one, what do we do with it?
Thank you so much, Julie, for that question and for that thorough answer, Dr. Brooks. Dr. Cooke, did you have anything that you wanted to add?
No, I'm just looking forward to vaccines for children, so we can all go on our family vacation.
Sounds good. Thank you. So our next question comes from one of our audience members, Catherine Turner. And I'm going to preface her question actually with some other questions that have come in. So Catherine asks, what do you think if a person doesn't take the second shot for whatever reason. And could we answer that question with, what if you either accidentally or intentionally get one shot of Moderna and one shot of Pfizer, or start with Pfizer and then decide you don't want the second dose, and then 3 months later you decide to get Moderna? Should you do that?
Take that, Dr. Cook.
I don't know that you can do that, but I'll let the doctors
Right,
answer that question.
Right.
Yeah.
Should you do that? Can you do that? What do we know about going back and forth?
Yeah, so I think that goes back to one of our earlier questions about whether these are FDA approved pharmaceuticals. And the emergency use authorization is based off of the clinical trials and how they were designed and the results of those trials. And these products were designed, so Moderna and Pfizer were designed to be 2-shot vaccines. And the trials didn't look at intermingling the different products, even though they were both mRNA. So really, when you're taking a drug, you really have to take the drug how it was meant to be taken, right? And not to do sort of improvisation with taking it that's not based in science or actual clinical practice or research observations. Now, the first dose of whether it's Moderna or Pfizer offers quite a bit of protection, and it's very has a high level of efficacy. So if something should happen where you physically cannot get that second shot, then you still are offered a high level of protection than if you were never vaccinated at all. But really, I would encourage people to not to play games and try to game the system, because it doesn't matter. All these vaccines are very effective, and really follow the instructions of our county and state health experts, such as Dr. Burke Harris.
And if I may add one other thing, my concern with getting one dose and not two is that your antibody levels may wane, because the second shot is, we call it a booster. It boosts your immunity. So if you don't get the boost, I am guessing that, and we don't know, because again, importantly stated by Dr. Cooke, the studies were done in a certain way. So you're asking, what if I do it different than the study? Well, we don't know. We didn't study it that way. But what's going to happen is that there's something called phase 4. You've all heard phase 1, 2, and 3. Phase 4 is post-marketing. This is how J&J actually got a pause, because after these vaccines are developed, the companies, they're going to monitor the people that are in the clinical trials for 2 years. So Dr. Cooke was involved. He still has more work to do. But it goes out for 2 years. So there will be some of these things happening, maybe not the commingling, but we'll know more. And there'll also be reports of people who only got one, or people that got it. So just wait to hear, but you're going off in a whole other direction. Like, I got a car that asked for premium gas. What happens if I put regular gas in? Maybe nothing in the first 6 months, but maybe your engine burns out 2 years sooner than it should have. So it's a reasonable question. I get it all the time. But it is one where you're do this at your own risk.
Mm-hmm. Thank you so much, Dr. Brooks and Dr. Cooke. Rhonda, let's move to you. A question that comes up quite often related to the vaccines is folks are holding out, if you will, for a certain vaccine to become available in their neighborhood, or they're essentially shopping around, for example. Can you speak a little bit to how shopping around for a vaccine does or does not contribute to us achieving herd immunity, and how that impacts health equity?
So I'm not quite sure what they're shopping around for, if they're just trying to make a decision about, Pfizer versus Moderna.
Right.
And so for me, I know that it's just hard to get an appointment, let alone which vaccine to choose. And so I think maybe that's I don't know if it's part of the whole vaccine hesitancy, that we see in the Black community, but to the point that Dr. Burke Harris made and Doctors Burke and Cooke have made, the most important thing is that these vaccines are safe and efficacious. And, taking the vaccine is better than dying from COVID, even if you do suffer side effects that at least I hear from folks who take the Moderna vaccine more so than Pfizer. So I think, considering how the Black community has been impacted by COVID, I think it's important for us to, I'm not saying that everybody needs to run out and get vaccinated, but I think the most important thing is for people to make a well-informed decision and understand, right, what the vaccines are and the truth and the facts versus the myths that have been circulating in the community. Some of the things that the doctors have said have addressed that, like if I take the vaccine, is it going to give me COVID? Or, again, not knowing if it's really meant to be effective in Black patients or not. So I think the most important thing is to, again, what's the trade-off? If you get COVID and not survive it, or take the vaccine and protect yourself and your family and the people that you care about at the same time. So,
I think,
so I don't know that you can really shop around, but like I said, it's really hard to get an appointment. At least it was before I left California. So,
and I want to echo Ms. Smith and maybe Dr. Brooks could talk a little bit about herd immunity, but I think when we look at the effect of COVID-19 on our Black community, I think we as we rightly should, we focus a lot on the fact that Blacks and Latinos and Native Americans die at a disproportionate rate after getting infected with COVID-19. But there are other things that we don't consider. For instance, what about educational disparities? Home learning and our Black and brown kids suffering at home for a year or more of home education. Many of us, the Zoom generation, we're working and distance working and working from home. But many in the Black and brown community cannot work from home. They're essential workers. Right. And many have transportation disparities. So they're forced to take public transportation as opposed to isolating, driving in a car. So these are all issues and more where we need to race to some level of herd immunity and that's vaccines, that's social distancing, that's testing, and in order to save our communities.
So Dr. Cooke made an excellent point. Okay, so he mentioned herd immunity. Herd immunity is simple, okay? If 80% of people are vaccinated, therefore they're not going to get COVID. That means if you have COVID and you're around these people, 8 or 10 of them won't get it. So 2 out of 10 may get it, and then they could spread it, but they can only spread it to 2 out of 10. So sooner or later it just dies off. If only 20% of people are vaccinated, then that one person that has it could spread it to 8 people. And then those 8 people could spread it to 8 people. It keeps going out and out and out. And the point he made is we are suffering disproportionately from being in a darn pandemic. Okay, 30% of us have jobs where we can't work remotely versus 18% of the majority community. We die 2 to 3 times as much. We don't have internet access, so we're not learning well at home. Like he said, the mothers have to go work. They can't be at home with their kids. So we are getting beat up by this pandemic, every way, shape, and form. We're losing jobs more readily. So another point, fundamental. The only way to get to the other side of this pandemic is through a vaccine, or a path strewn with dead bodies. We have enough dead people. The pandemic is over. Everyone's dead. So it is imperative that we get to herd immunity. And for those people that are waiting and waiting and waiting, they're at risk for COVID. So then they're slowing us getting to herd immunity. The other thing is those variants. As the vaccine spreads, that's how those variants come. The virus figures out how to beat our immune system. you stop it from spreading, you stop more variants. So those, and Rhonda Smith said, what are they waiting for? What are they shopping for? Okay, you know, it's vaccine A and vaccine B. And if I showed them to you, you couldn't tell the difference. I also think, last thing I'll say, I don't know how many there are, but Dr. Cooke may know, there are probably about 12 different influenza vaccines. So I've never heard anyone come to me and say, well, sometimes a little bit, but generally people don't come to me and say, I want flu block and not flu zone. You know, people will say to me, I would like maybe the nasal spray versus the shot. But I've not had people coming to me requesting a specific brand of flu vaccine. So it's interesting how all these things are arising de novo or new with this particular vaccine.
Wonderful. Thank you so much. So we have a few more questions that we will take from our audience, and then we're going to talk a little bit more about harm reduction. And you know, you've been vaccinated, so now what? So our first question is around how long the vaccines last. Do we have any updated information about how long the vaccine will last? That's the first question. Dr. Cooke, do you want to start?
What we hope is that we will have that information soon. I do know that Pfizer is continuing clinical trials, brand new clinical trials looking at booster shots. So people who have received the vaccine and they either get booster or placebo. And then for people like me who are participants in the original phase 3 trial, that's the large multi-institution national trial. They are continuing. I have to, be a part of the trial for 2 years. And so they will continue to collect, my blood. And I have a little app on my phone that reminds me to fill out symptomatology. And I assume that the app will be automatically upgraded when my iPhone gets upgraded. So, and they asked me not to move, so they could keep track of me. So we hope to have this information forthcoming.
And there was information that came out, I want to say 3 weeks ago, that Pfizer is out at 6 months, shows protection for 6 months. So that doesn't sound like long, but it's probably, that's all we have. I mean, we can't tell people it's lasting a year when it's only been 6 months since they got the vaccine. So we do have some updated information.
Thank you. Wonderful, thank you. So this next question is for you, Dr. Brooks. We have a maternal infant health question. Should pregnant women get the vaccine? And also from Monica King in our audience, if a mother is still nursing, should she get the vaccine?
Okay, so pregnancy puts you at higher risk for COVID-19 adverse events, hospitalization, and death. The American College of Obstetrics and Gynecology states it this way. They said a woman should not be denied the vaccine and should consider getting it. So basically they're saying that yes, when you're pregnant, you should get the vaccine. The study did not have pregnant women in it, but there's been post-marketing after the vaccine has come out that there has not been shown to harm pregnant women. So I will go with ACOG, American College of Obstetrics and Gynecology, and say get vaccinated. They say this doing it in conjunction with your obstetrician. So if you're pregnant, ask your OB, okay, and see what they say. If your breastfeeding answer is absolutely, because you're not pregnant, first of all. And what happens is when you get vaccinated, we're seeing antibodies going from your immune response going into your breast milk and into the baby. So you're actually protecting the baby. So the answer is definitely you can get vaccinated. If you have been vaccinated, you can breastfeed. And then on the side, as a pediatrician, breastfeeding is the way to go. So forget those formulas and bottles, breastfeed.
Wonderful, thank you. We're going to take one more audience question, and then we're going to move on to our harm discussion. questions. So around mutations, have any new or mutation strains of COVID been identified? And can you tell us about their threat?
I can speak to that, and then I'll just start to put my head in. There were two mutations that have come up in the last approximately month or so that came out of California, Southern California, out of the jails. There was literally an article today that I didn't get to read, but I saw the headline that there is some thought that these mutations may actually be beneficial because it may mutate to a less virulent, a strain that doesn't tend to do much to you, but it stimulates antibodies, and then you're immune to the more deadly strains. In general, what we're seeing is the UK strain seems to be more contagious, not necessarily more deadly. South Africa seems to be more contagious and may be a little more resistant to treatment with autoimmune, monoclonal antibodies. My thought is this is very interesting. And I think that for those that are asking questions like this, keep abreast of information, but it really doesn't change anything. You still get vaccinated, you still follow CDC guidelines, you wear a mask, you wash your hands as indicated.
Yeah, as we look at the state of Michigan, a lot of that outbreak is, or rising cases is thought to be related to mutated strains. But we do know that when you look at viral behavior, virus behavior, especially coronavirus behavior, mutation is relatively common. And especially as we have so many people who are infected with various different immune responses, the virus is going to mutate, just like the common cold, which is a coronavirus as well. But I think going back to the vaccines, you look at the Johnson & Johnson, I'll talk about Johnson & Johnson because that's the most recently released data. And also a lot of that clinical trial occurred during the outbreaks of these mutations, especially in South Africa. Again, we look at they reported that their efficacy in South Africa was around about 50% or 55%. Keep in mind that the flu vaccine, 50% efficacy for flu vaccine is considered like a home run, okay? But that was efficacy for whether or not being infected with COVID-19, because they had a high level of the variant in South Africa. But the folks who received the vaccine had 0 deaths and very few hospitalizations. I'm not sure whether the 2 hospitalizations in the study were in South Africa or in other countries of the study, but 0 deaths. So it goes to show that these vaccines are extremely protective from death from being infected with a mutated strain of COVID-19.
Wonderful. Thank you so much for that. So we know, so the governor has recently announced that we will be moving to reopening in the state of California. And with that being said, we know that we must all do our part to keep ourselves and our communities safe and those that we love. Let's talk a little bit about harm reduction. Let's sort of start with, so after you receive the vaccine, do you still need to continue to wear a mask? And around the discussion of masks, what kind of mask should folks be wearing? How should the mask fit? What are the details of, masking 101? Let's start with Dr. Brooks.
Okay, so I would say I just have an abundance of caution. So I know that if I go out in a public gathering where will be less than 6 feet from people who I don't know, in other words, I don't know their status, that I will be wearing a mask. A mask should fit snugly, should have 3 layers is the best. And people are, or double masking is good. If you breathe, they should not fog up your glasses. if you're wearing around your, if it's kind that you have to loop, make sure that they tie around your ears and fit snugly. The best mask, quite frankly, is an N95. If you can get that. If you don't have an N95, you can just wear what we call a procedure mask, which is the mask, the blue mask that you see other people wearing. And to me, the most important one is it should cover your nose. It's obviously going to cover your mouth. But I would say 1 out of every 5 people I see are wearing a mask right here. So that is ineffective. And masks, and the last thing I'm gonna say this, masks afford some protection for you, but the regular, the non-N95, a regular surgical mask, procedure mask is primarily to stop you from giving it to somebody else. So do remember that. So that's why even if you're wearing a mask, if you're out, I personally try to keep my distance and wash my hands, but that we were talking about masking.
Perfect. So Dr. Cooke, I'm going to give this last one to you. This is a question that folks are asking, so I think that we should address it. What should you do if you decide to host an event or if you are planning to attend an event? What are some precautions we should be taking?
Sure. Well, first I would follow your county recommendations and guidelines for public gathering. And those are all readily available on your county website or the California public health websites as well. Now, I think it's really contingent on who's vaccinated and who isn't. If everyone at the gathering is vaccinated, then definitely while outside, and there aren't other individuals who are not part of this group that aren't vaccinated, then you potentially could go without wearing a mask. And even inside, if everyone is vaccinated. If there are individuals who are unknown status or individuals who are not vaccinated, then wearing masks are key. Outside gatherings are preferential than inside gatherings as well. In regards to travel, the CDC has released travel guidelines. So if you're vaccinated, then essential travel is what you can do. Obviously, it's very difficult to define what is essential travel, right? And you could read the CDC's website for more of that information.
Wonderful. Thank you so much, Dr. Brooks and Dr. Cooke. So before we end today's town hall, we're going to hear from Rhonda Smith. She's going to talk through the important role of equal access and distribution of COVID-19 vaccines, and what role does that play in preventing the widening disparities for Black and African Americans in the state of California. Rhonda?
Okay. Thank you, Shantae. But before I do that, I wanted to ask the doctors a question because I've been hearing this a lot lately, and I want, at least for my own edification and for the benefit of the audience too, it's like, can you talk about what is long COVID? I hear that term being used by some folks that I've been around lately. And I thought it would be good for all of us to understand what that means and what that is and what we can do about it if an individual is dealing with long COVID.
Yeah, so I'll speak to that first, and because that's actually my greatest concern. My greatest concern, I mean, is I figure 10% of people get COVID, get hospitalized, 1% die. I figure I'll beat those odds. But long COVID. So there was a study in China. 75% of those that were hospitalized, those are more severe cases, had symptoms 6 months later. 13% had kidney disease. So I think it comes from the fact that it is an inflammatory condition, COVID-19, the body has an inflammatory response. And so it can cause long-term problems. So when people worry about the vaccine, I say worry about the COVID long-term problems. So the most common findings are headache, fatigue, and I believe, joint pain. So what long COVID is symptoms, I think is defined 3 months after you've cleared your COVID infection. And we don't know a lot about it because this has only been around since, let's say, we saw our first cases in Seattle in January. So COVID has only been around for 15 months in America and what we're looking at. So it is symptoms of unexplained symptoms that we are linking to COVID infection that occur after you've had the infection. We have no idea what to do with people who have these symptoms. And it's going to be, I believe, a large number. We've had 550,000 cases in the United States. So let's say even if 1% get that, that's 5,500 people. There are going to be more. 2%, that's 10,000 people. So that is something to be very concerned about for those that say, oh, I could get COVID, but I doubt if I'll be hospitalized, sick, or die. You still are at risk for long COVID, as it's called.
Okay, great. And enough, Dr. Cook wanted to add anything to that?
No, I think that was well said.
Okay, great, thank you. So I will try to wrap up and talk about why equal access and vaccine equity is important. And we've talked about the fact that Black and Brown communities have been sort of the hardest hit when it comes to COVID, contracting COVID as well as succumbing to COVID. And so, even here in California, like the rest of the country, even before COVID, Black Californians and Black Americans had the highest rate of, the lowest life expectancy compared to all other race and ethnicities. And that difference here in California was about 6 years. And so COVID, obviously because of the disparities, has widened that gap. And so all the progress that has been made over the last decade or so really has been lost, unfortunately, because of COVID. And so it's been estimated that the life expectancy has been reduced for Blacks by 3 to 4 times compared to white Americans. And that gap is about a 39, almost a 40% increase. And so, it's important for us to really consider, especially for the percentage of folks that I call on the fence about COVID and are vaccine hesitant, to really understand the benefits of versus the risk of taking the vaccine and what the implications are if you don't, especially as Dr. Brooks talked about earlier, getting to herd immunity. And so when we look at, who's getting the vaccines versus how we represent the total population here in California. So, we're only getting, or Black Californians are only 3% of the vaccines or vaccinations that are happening when we represent 6% of the population. So there's disparities there. And we know that vaccine equity is an important goal when we talk about, really preferential access and prioritization of Black and Brown populations, which are the ones that are most affected by COVID. And we know that that is the way that we're going to be able to beat this disease, or at least survive it. And then reaching high vaccination rates across California amongst Black and Brown communities and is key to achieving broader population immunity through the vaccine. So we all need to do our part, even if we are vaccinated. It's still important, to Dr. Brooks's point, to practice extreme caution and continue to wear your mask, continue to practice social distancing, and make wise decisions. I miss going out and socializing, but I'm also very cautious about who I'm around, where I go, even if the restaurant is outdoor or has outdoor seating, I'm really cautious about going to unfamiliar places. And so I think we just have to continue to be vigilant about how we're living and being and doing every day, so that we can continue to move towards, if you've seen the campaign in California, let's get to immunity, with the emphasis on unity, because we're all in this together and we all have to be mindful about what we're doing and taking care of ourselves as well as our community. And so we hope that you've enjoyed the conversation today and are able to take away a few nuggets that can help dispel some of the myths that you may have heard in the community. And also, if you're on the fence, convince you to get the vaccine or at least build more confidence there. And so if you have any further questions, put them in the chat. And we hope that you continue to be vigilant and help us get toward immunity and to help end the pandemic, not just here in California, but across the country. So with that, I want to thank the sponsors of the event today. I want to thank my fellow panelists and all of the organizers for the event. Definitely Dr. Nadine Burke Harris for coming in at the last minute and sharing information about the J&J pause. So with that, I'll turn it back over to Shantae and you'll take it home from here.
Thank you so much, Rhonda, for those great comments. And thank you, Dr. Brooks and Dr. Cooke. Very helpful information. I know I learned something. I'm going to have to go look up that new word, Dr. Cooke, to see if I can get that down.
Thrombocytopenia.
It just rolls right out. So I just want to remind everyone that tomorrow is April 15th, and no, that's not tax day. Everyone is eligible for your vaccine tomorrow. It is everyone's turn starting tomorrow. So you can register at myturn.ca.gov. You can also call the hotline, and if we can put the number to the hotline up on the screen, there we are. The phone number is 1-833-422-4255. Again, you can register to get your vaccine at myturn.ca.gov or by calling the hotline. We again just want to thank everyone for their time this evening. Thank you for joining. And another thank you to our California State Surgeon General, Dr. Nadine Burke Harris, as well as our sponsors, again, the California Black Health Network, California Department of Public Health, the Sierra Health Foundation, our California Vaccinate All 58 campaign, and yeah, just a big thank you. And then lastly, our vaccinateall58.com. That was also up on the screen, but you can find more information there. And so again, thank you, everyone. We appreciate you attending and stay safe.
Thank you. I really appreciate it.
Thank you very
Thanks,
much.
everyone.
Thank you, guys. Have a good night.
Bye-bye. Get vaccinated, everyone.
All right. Agreed.
Thank you.